Another fact is that thyroid cancers do metastasize to the regional lymph nodes. We all know that in this audience we have good skilled surgeons. Probably their experience is more than my age alone. But the purpose of today's talk is not to talk about my experience or their experience. The purpose is to talk about the most up-to-date evidence so that we reach the optimal outcome when we are dealing with these malignancies. So what is the clinical equipoise? Is there any clinical significance of regional metastasis in thyroid cancers? What is the difference between micro and macro metastasis, and does it has any role in the outcome in terms of survival or recurrence? And if there is a recurrence, does it matter? And does it impact survival? So we know that thyroid malignancies do metastasize to the different cervical lymph node levels. The most common one is level 6, followed by level 4 and 7. We also know that 22% of the patients have skip metastasis, and this usually is from the upper pole malignancies. 35% of the papillary thyroid carcinomas, when present, have clinically T1 disease, and up to 80% of these malignancies have micrometastasis. So what is the clinical significance? Back in 1996, Shah from Memorial Sloan have tried to observe the impact of lymph node metastasis in differentiated thyroid cancers in a matched pair analysis, and he concluded that nodal metastasis in older patients more than 45 years of age have increased risk of recurrence without any survival benefit. Then in 2015, Adams et al. Have concluded that patients less than 45 years with nodal positivity have increased mortality risk as compared to those with clinically negative NEC. And lymph nodes, which are positive in terms of number, more than 6 lymph nodes, have increased mortality risk. The Surgical Affairs Committee in 2012 have concluded that 24% recurrence risk is present with nodal positive disease when there is extranodal extension. And in 2018, Amit et al. Have also shown us that the lymph node burden or density has a significant role in the outcome in terms of disease-specific survival and overall survival. So when it comes to micro versus macro metastasis, there is this very interesting study by Randolph et al. Published in 2012, and then another paper from Bozek in 2011, telling us that macroscopic disease impacts prognosis. Microscopic disease, no impact on survival and recurrence. Occult nodal metastasis disease, no impact on prognosis. So what is the purpose of central compartment lymph node dissection? So when I'm talking about the central compartment, it means level 6 and 7. I'm sure you must be knowing the boundaries of level 7. So when you perform the central compartment lymph node dissection, there is a case that there is decreased risk of recurrence. But remember that it does not impact survival. And the risk of recurrence resides with the macroscopic disease, not the microscopic disease. There are two large population-based studies in 2006 and 2008 from United States, telling us that the increased mortality rate with lymph node metastasis in differentiated thyroid cancer is more in follicular thyroid carcinoma, PTC with age above 45 years, and when there are bulky nodes with extranodal extension. So there are a few factors that are associated with nodal disease in differentiated thyroid cancers: patient's age, tumor size, histology, and genotype. It is more common in younger patients, more common in larger tumors, more common in papillary, followed by medullary and follicular, and it is more common in patients with papillary thyroid carcinoma having positive BRAF mutations. So what do you need to do when it comes to the evaluation of nodal disease in thyroid cancers? You need to have a complete comprehensive history, physical examination, and some of the key clinical features in ultrasound, such as microcalcifications, loss of fatty hilum, peripheral vascularity, the shape of the node, which should be more rounded than oval, and hyperechogenicity. You can also measure the thyroglobulin washouts from the node, and you can further strengthen your diagnosis using CT scan and MRI. CT has a better role as compared to MRI when it comes to the extent of the disease in nodal metastasis. So there are always opponents and proponents of central compartment lymph node dissection. The established fact is that microcarcinomas less than 1 centimeter, they still have high risk of occult metastasis to cervical lymph nodes. But what matters most is the outcome and prognosis. There has been studies from US-based institutions telling us that there is no survival benefit. The Japanese were more favoring aggressive approach, but limited evidence in terms of literature. And the increased incidence of recurrent laryngeal nerve injury and parathyroid injury really questions the role of central compartment lymph node dissection. So when it comes to central compartment lymph node dissection, we broadly categorize into two subsets, the prophylactic part and the therapeutic part. So you do the therapeutic neck dissection when there is clinically or radiologically evident or pathologically proven lymph node in the central compartment, or when there are positive lateral compartment disease. When I'm talking about the lateral compartment, it means disease at level 2 to 5. So generally not recommended for papillary thyroid carcinoma until there is a burden of the disease, which means T3, T4 tumors, or when there is lateral compartment disease. We don't have trials so far to evaluate value of prophylactic central neck dissection in clinically node negative papillary thyroid carcinoma. But there is one reality, which is that high volume centers with experienced surgeons have less morbidities. So the next thing is the risk associated with central neck dissection. So the risk for temporary hypoparathyroidism is 14 to 40%. It's a vast range. The permanent hypoparathyroidism can happen in 1.2% of the patients, where there is a need for calcium replacements beyond 6 to 12 months, and risk could be more in low volume centers with inexperienced surgeons. So what is the injury to recurrent laryngeal nerve? Again, the risk resides more with the low volume centers, inexperienced surgeons, and you can clearly see the difference in terms of the percentages. So this is a very good slide by Randolph. He has published it in his paper that was published back in 2012. You can clearly see the risk which is associated with clinically node negative, pathologically node negative disease, clinically node negative, microscopically node positive disease, and then there are less than 5 lymph nodes involved. So the risk is less than 10% in all these scenarios. The risk increases only when there are more than 5 positive lymph nodes or when there are nodes with extranodal extension. Okay, so for low intermediate risk with T1, T2 disease, non-invasive, node negative, one has to define the risk-benefit ratio before you embark your commitment to the central compartment neck dissection. Central neck dissection only if clinically node positive disease, but for high risk patients, and when I'm talking about the high risk category, it means old or very young patients, T3 or T4 disease, multifocal disease with extrathyroidal extension or non-lateral neck positivity. 83% of patients with lateral neck nodal positivity have positive paratracheal nodal disease, even in the absence of negative ultrasound. So occult contralateral central compartment positivity is 34.3% if having ipsilateral multifocal disease or positive ipsilateral neck nodal positivity. So the next question is about the unilateral central compartment neck dissection or the contralateral central compartment neck dissection. So the lymph nodes that I'm talking about are the prelaryngeal, pretracheal, and paratracheal lymph nodes. So if clinically nodal disease is present in both paratracheal region, you will go for bilateral central lymph node dissection. But when you are doing bilateral central lymph node dissection, it means you are risking injury to the recurrent laryngeal nerve and hypoparathyroidism with no reduction in risk of recurrence. So preoperative ultrasound in combination with intraoperative central compartment inspection would definitely assist identification of suspicious lymph nodes, but the risk will always be there. So the next thing is the lateral neck dissection, which means removal of level 2 to 5 lymph nodes. And the indications to address these lymph nodes is that there has to be extensive nodal disease in the central compartment. There are documented nodes in the lateral compartment. 25% of patients with clinically negative disease have microscopic lateral nodal metastasis, but it does not mean that this situation translates into poor prognosis and eventually poor survival. So there is no role of berry picking, no role of selective sampling, and no role of inadequate nodal excision. So this is your lateral compartment starting from level 2 to 5. So the extent of neck dissection, it has to be level 2 and 5. The question is about level 1 and level 2 to 4 is something that you do on routine basis. Level 1 and 5 questionable. The risk of metastasis to level 2B is 6%. So one has to be careful when you commit yourself to remove level 2B, because then you would be risking spinal accessory nerve, because there's a lot of push and pull, a lot of stretching to the nerve. Even if you're not sacrificing the nerve, still you will be facing the morbidity in terms of shoulder dysfunction in the postoperative period. So the risk of metastasis to level 5A is 11%, but routinely you address level 5B only when the disease is T4 and it is more than 4 centimeter, because then the risk increases. So overall survival is 100% with biochemical evidence of persistent disease. So you may be having biochemical positive disease, which can worry you, but remember that the overall survival is 100%. So overall survival is 85% with structural evidence of persistent disease. Overall survival decreases when there is distant metastasis, and that decreases to 50%. So what bothers you is the presence of central and lateral neck nodes. So this is the scenario that you very often face in the recurrent or persistent disease setting. So if there are central nodes which are more than 8 millimeter, or if there is a lateral node which is more than 1 centimeter, you can further strengthen your suspicion by using ultrasound guided FNA or nodal thyroglobulin washouts. So the only rational factor which can direct you to explore this persistent or residual disease is the presence of that disease in proximity to vital structures, which means recurrent nerve, esophagus, or trachea. So the surgical removal of metastatic nodes may not result in undetectable TG levels in 50% of cases, and that has no impact on overall survival. So the risk associated with lateral neck dissection, as I mentioned earlier, that there can be an injury to the spinal accessory nerve, which can be temporary or permanent, more common when you are dissecting along level 2B or 5A, because there is a lot of traction that can cause devascularization. There can be injury to the motor branches of the cervical plexus, but you can decrease that risk by using intraoperative nerve monitoring. And if that happens, or you're anticipating an injury, you can send the patient for postoperative physiotherapy. There's a risk of thoracic duct injury, for which you can do multiple maneuvers if that happens. And then you can cause injury to the phrenic nerve that travels between anterior medial scalene muscles, marginal mandibular branch of the facial nerve, or the brachial plexus. Yeah, I think I'm probably have taken only 15 minutes. Okay, so the final comments, benefits must outweigh risks. You have to keep in mind that there is a risk of injury to the nerve, which can be life-changing. There is a risk of hypoparathyroidism. When there is a borderline situation, you can always take your patient back to MDT, rediscuss with other consultants, colleagues, to reach optimal outcome. One has to consider patient in this decision making, because everything revolves around the patient. So patient has to be motivated. He has to be involved in decision making process. There are lack of prospective and randomized control trials with long-term follow-up to compare outcomes. Uh, there is clinical equipoise always whether to do close surveillance or to do surgery. Talking about the biological markers, there is no clear prognostic indications that really question their clinical applicability. Thank you.
Thank you very much, Dr. Faisal. I would request Dr.
Yes,